Okay. So we are group 6 talking about the major depressive disorder case study for 384. Our patient is Marilyn Smith. She's 28 years old. Um, so the first part, the history, is Marilyn Smith is a single African American 28-year-old female. Oh, sorry.
Sorry. Also Mexican hot chocolate
Sorry.
from
Okay, recording. Sorry.
yeah, hold
Sorry, guys. Okay. Okay. The history of this patient. Marilyn Smith is a single African American 28-year-old female who presents to the emergency department with complaints of feeling crummy for the past 6 months. She reports that she no longer feels like doing any of the things she used to enjoy. It all seems so pointless, she says. She can't even bother to eat most days and has lost weight recently. Although she has no energy, she finds it difficult to both fall asleep and stay asleep. Even when she does manage to fall asleep, she never feels rested when she's awake. She reports having difficulty at work as a computer support person because it is so hard for her to concentrate. Last week, she called in sick and spent the day in bed crying off and on all day. Last night, she found herself crying again, and this time she also thought about suicide, which scared her and prompted a visit to the ED. I don't want to live like this anymore. I feel like I will never be happy again.
I
That
can
was
take
the.
over on reading the personal, so you're not reading it all.
Okay.
Marilyn graduated from high school and obtained an associate degree in computer science. She enlisted in the Army to have an adventure and hoped the GI Bill would pay for further education once she completed her service. She reports she still feels guilty about making the decision to enlist instead of marrying her high school sweetheart. She was deployed to Iraq and returned home a year ago. She enjoyed her time in the service because she felt she was doing something useful for her country. She did not see combat and did not experience any significant problems while in Iraq. When she returned home, she found out her old boyfriend had married. She recently attempted to contact local universities to explore completing her baccalaureate degree and found out the process too overwhelming, just gave up. When questioned about use of alcohol or drugs, Marilyn reported that she is an occasional drinker, but recently has been drinking more in an attempt to sleep. Denies other drug use. Marilyn has no history of clinical depression. Her grandmother had periods of becoming withdrawn and not leaving the house for days. So relevant data.
Okay. It seems like there's a lot of like physical attributes that she's dealing with, both physical and mental. Something that she said above was, it seems so pointless. So this can kind of point towards depression. She no longer feels like worth and joy and doing things that used to matter. She's being a lot of withdrawn, and she's also having a hard time just going throughout the day. She's not eating. She doesn't seem to have any energy. Having a hard time falling asleep and staying asleep, which can all kind of point towards depression. Um, let's see.
Cannot concentrate at work, having difficulties with job role. Um, which again, if she's feeling depressed and having issues with that, then obviously that's going to affect, not sleeping, and then bringing that to her job, not having the energy like we talked about earlier, and then thoughts of suicide, obviously probably the most that stands out to everybody in this. Suicide can come, like clinically, suicide can come from all sorts of different areas, but if she's feeling depressed, she has no energy, she's not sleeping,
Mhm.
major depression can then lead to the thoughts of the suicide.
Yep. Yeah, definitely the suicide is now an urgent matter. Therefore, showing up to the emergency was a really good thing. So she can get that professional help that she needs. So there can be like interventions, evaluations done ASAP.
Yeah.
Then,
Anyone feel anything else from that information?
yeah, history, what she's dealing with right now.
Yeah.
Yeah, I'm just my only question is um her alcohol use. Would you put that under relevant data from present problem or social history?
Probably social.
I know,
More,
it's like it kind of feels like it lives between the two, so I
yeah.
don't really.
It really blends in between. Yeah, you're
It
right.
does.
Social and also present.
Because it didn't really feel like it was a social drinking, but I was just curious what your guys' thoughts were.
It's kind of. It's probably a personal, just because it's not doesn't have to do with other people. As in an attempt to sleep, she's drinking more than normal. She's an occasional drinker. She's not going out, so
Right.
it's probably going to be more of the personal.
Okay. I can add it if we wanted to.
Yeah, we had that one.
Yep. And then all of these symptoms, we have to kind of look towards her like personal history of what brought her to these emotions. Something that stands out is she felt guilty going to the military instead of getting married. And I think this probably exacerbated when she was already also in Iraq. It's like a cycle of just feeling bad, feeling regret.
Yeah,
Um, and something that stood out was that she did not have any major issues or see combat while overseas.
yeah,
But yeah.
yeah. And I think like being prior military with it is that like that's a very normal thing within the military. Um, honestly, it sounds bad, but the drinking isn't more because that's just such a relative like social thing within the military, whatever branch you're in. So, but yeah, for sure that. And then, I mean, that kind of moves into the social side of things. Yeah, good there.
Um, does it say she has a family history of depression?
Yeah, her grandmother, but it was like kind of up in the air. Like it didn't sound like she ever got diagnosed. It was more like she was withdrawn. And what did it say?
I missed that.
Her grandmother had periods of becoming withdrawn and not leaving the house for days.
Mhm.
Sounds
That's
like
a
it was
really
her.
good distinction. So it doesn't say like specifically grandma had like depression. It just says it just seems like it's very an observation. So there could be something more to that. Could possibly be genetically linked, or it could also be like a family stigma. Maybe if grandma didn't seek help, then maybe she won't be prone to seeking help.
Yeah, that's a great idea. Actually, I hadn't thought of that. Yeah, maybe that's like a social stigma.
Yeah, especially generational wise. So
Mhm.
Okay.
cool, cool.
Anything else for social history? Let's see.
A year ago, Christian drinking habits, sleep. Um,
Yeah, do we want to add, do you want to just add like perhaps family stigma, or how would you say that?
Yeah.
Yeah.
Yes, I can definitely add that. And then does anything stand out for the vital signs?
No, it looks like everything's in range. What do we think? No current pain.
Stat on room air. No, it's not a group pain. Sun on room air.
Yeah, doesn't her emotional mental status doesn't seem to be quite affecting her physically, I guess, at this point.
Yeah.
Or at least not in ways we can measure.
right, pick up on
There's no
your
pain causing issues either.
Yeah.
Mhm.
So
Yep. Something that stands out is her O2 sat is 99. So she's not like having really high or low oxygen that's affecting like, sometimes
Right.
anxious
Yeah.
in a state can lead to like hyperventilation. So it doesn't seem like that's going on here.
yeah. Doesn't seem like, like I think that just shows that it's not like an anxiety attack or something like that that's going on currently. Um, just being able to rule other stuff out. Mental status examination, appearance dressed in casual clothes, somewhat disheveled, no makeup, no body odor, appears tired, uh, and appears stated age, cooperative during interview, motor behavior, wringing hands during interview, speech is a little slowed, slow to respond to questions, does not elaborate unless asked, mood and affect, appears sad, reports feeling anxious and sad all the time, feels like she will never be able to feel better. Thought process, logical and linear, thoughts make sense and are connected. Thought content, reports feeling of guilt for feeling so bad for no reason and for leaving her boyfriend all those years. Reports having ruminative thoughts. Ruminative thoughts.
Ruminate.
Ruminative, my bad. Thoughts that she is of no use to anyone, worthlessness, denies delusions or paranoid thoughts when assessed, no evidence of psychotic thinking or loss of contact with reality perception. States she's occasionally hears her name at night when attempting to sleep, but knows it is her imagination. Denies any other hallucinations, illusions, or depersonalization when addressed. Insight, knows she doesn't feel right, but does not recognize symptoms as part of clinical depression, unable to identify any uh, precipitant, judgment intact as evidenced by seeking help, cognition. Alert and oriented by three, recent remote memory intact as evidence by how she answered interview questions, demonstrated ability to I just clicked the button and it all went away.
Demonstrate ability to abstract when tested by asking about proverbs. Fund of knowledge and intelligence is at least average based on vocab used by the patient. She reports having difficulty concentrating. When attention span was tested using serial 7 tests, patient declined to participate. She also reports withdrawing from friends prior to the admission, unable to assess currently. Patient admits that she thinks about suicide, but would never act on it because she wouldn't want to hurt her parents. She has no plan, but when she thinks about suicide, states that she has her own gun at home, denies homicide, ideations, and thoughts of self-harm. Okay, so
Okay, great. So we're disheveled, fatigued, wringing hands, slowed speech, delayed response. Like these are all pretty normal. Am I the only one who was like kind of surprised by the ANO times three?
Yeah.
Yeah, and so I also have a problem with this because if you look down further,
Uh-huh.
in the next section for neuro, it says ANO times 4.
oh,
So
Interesting. I wonder if maybe she's like wasn't paying attention because she was having attention problems or something,
Could be.
yeah,
or if it's just inaccurate in general. Um, as I said, mild perceptive disturbance, socially withdrawn, passive suicidal ideation with firearm access, judgment intact. I feel like these are all just like such like classic manifestations. It makes me curious why she doesn't like link the two.
yeah. Yeah, the passive suicidal ideation is a big part, especially with firearms access.
Mm-hmm. Does anything else stand out to you guys?
Not really.
No, not really.
I know it's like such a like not cookie cutter. I don't want to say cookie cutter, but
Yeah, nothing stands out from out of the ordinary.
mhm.
I do think it's interesting that she hears her name when she's trying to go to sleep, just because I know other people who they also experience that.
Oh, okay, good callback because when I was also like, wait, what do we think this is? Because then it opens, up so many options.
Yeah.
Yeah. And then I think that also brings up like the fact of that, like she was talking about alcohol, like we're not getting a aspect of like what she considers a normal amount or non-normal amount because everybody has their own, I mean, obviously there's clinical reasonings behind how much is too much and not
Hmm.
inappropriate, but if she's drinking more and then now hearing her name, or was that happening
Right.
before or so?
Hmm.
Yeah.
Yeah, I also don't know like if it sounds like a voice she knows or just random. Like,
Yeah.
who knows?
Mm.
Who knows?
So I think it just asks questions. I mean, if you're in that setting to like further go on to that and try to get more information for that, because it's kind of, yes, she's able to push it away, but why is that happening and when is that happening? So, because it could be from the lack of sleep that she's getting, or it could be from the alcohol, or it could just be a big mix of all of it. So,
Hmm.
Mhm.
Absolutely.
cool.
Okay. Do you want to go into current assessment if we don't have anything else we're thinking
Yep.
about?
Yeah.
Okay. So general appears somewhat tired and anxious. Respiratory breath sounds are clear bilaterally. Non-labored, cardiac, pink, warm, dry, no edema. Heart sounds regular, pulse is strong, equal, palpitations, risk tap refill, neuro alert energy times 4, like you said, GI, abdominal flat, soft, non-tender, bowel sounds and all 4, GU voiding without difficulty, urine clear slash yellow, and then skin intact, turgor elastic, and no tenting. So points to again. It sounds like to me basically like from this, I don't see anything like really standing out physically. Um, just the anxious that stands out, right?
Yeah. I think
Yeah.
I think what it's really showing is that there's not something, at least in this assessment, is that there's nothing that physically that stands out that's saying, okay, we can link this to this and link this to that, possibly link it. I think it's just showing that there is less of a physical issue going on and more of a mental issue.
Yeah.
Agree, disagree?
Agree.
Cool,
Mhm.
cool,
Absolutely agreed.
cool, cool. I think we can just move on to the next.
Yeah. Okay. How does everyone feel about labs? Our sodium looks normal. Our potassium looks normal. Glucose, creatinine normal. White blood cells, I forget the range.
They're a little low, but they're normal.
Okay. Um, neutrophils, hemoglobin, platelets. Platelets are low. Not low, but lower end. Um, and thyroid. I don't know nothing about thyroid. Okay.
Did anybody look them up?
I'm looking it up right now.
I was like, once it gets out of Google, I forget right out of my brain.
Same. Let's see.
Okay, can someone read TSH, right? Is what it is.
THS 8.
T3, T4, and TSH. Blood test T3, T4, and TSH. All right. TSH would be 0.5, or excuse me, yeah, 0.5 to 4.2. T4 would be depends on what levels they're showing it in. 82. Okay. This can't be right. Because that's showing 82 and this is showing 0.9 to 1.7. What are we multiplying by?
Yeah, see, and then I have something from like our farm class last semester, and it says
Okay.
like 2 to 10. Like that is a very different number.
For T4?
Yeah.
Okay.
Where? Do you have that as notes or in one of the books?
One of those many papers they gave us throughout
Oh,
the
yeah.
yeah, it's one of the few I kept. The one that's like maroon.
Oh yeah.
Yeah.
The thyroid gland
Um,
function 483 to 484.
So they are crazy.
That's what I'm.
whoever did the lovely mildly elevated.
Mhm.
Nothing on the card they gave us last term.
I know. No, these are just drugs.
So
What are the ATI 23? So I have like all the textbooks that we get right here.
Yeah, right.
so they're all high,
Yeah.
but especially T4.
Nutrition. Mental mercy.
Yeah, I wish it gave us like what it was, the
Yeah.
like units or whatever.
Especially like the exact values because that's not saying like what the rating level is that they're talking about here.
Mm-hmm.
We can move on to the next one so we're not stuck here, and I will continue to look through the books to see if I can find.
Okay,
Does that work?
Yeah.
that sounds good. Yeah, weird. Okay, what is next? Okay, put it all together, nurses. Our major problem, major problem, our problem, depression, um, pathophysiology. What does everyone know? So depression is a mood disorder. We know it by like persistent sadness, loss of interest in like their normal daily activities. Um, I don't think it's clearly defined, but a lot of studies show it's connected to your neurotransmitters, um, your serotonin, your dopamine, your norepinephrine. Um, and these are what are affecting our mood regulation, our sleep, appetite, concentration. I immediately think of like SSRIs, like serotonin regulation. But for Miss Marilyn, she is presenting with withdrawal from social activities, the tiredness, the difficulty in concentration, the crying, the hopelessness, the insomnia, the weight loss, guilt, thoughts of suicide, all major factors of major depression. Does anyone else have any other thoughts on it? Or does anyone have any knowledge they would like to share?
Sounds good.
Right. Okay. So our next session is medical management, rationales, and expected outcomes. Do, 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 do. So our first one is admit patient to unit under voluntary admission. I mean, obviously, I think we can all agree that she kind of needs like around the clock care, probably away from her firearms, and like that intensive treatment, in the unstructured environment. What would be the expected outcome? I guess just safety, right? In a voluntary admission.
Yeah, I think
Yeah.
so. Unless
Um,
crazy. So.
sorry, what'd you say?
I said unless her thyroid is crazy. So
Right? That's all true. Hey, it'll be
I know, right?
perfect.
I'm
She's
still
there.
looking all over the place.
Okay, initiate milieu therapy. Provides therapeutic social environment. Um, Maybe she would engage with peers, maybe not. Definitely gives her a chance to engage with staff in like a therapeutic setting and not like treat her social withdrawal, but get her out and about.
Yeah, it kind of goes back to like distractions sometimes, just like keeping busy, talking
Yeah.
to others. It just kind
She needs some mental stimulation other than what's
this
going
would
on.
find people to relate to. That might.
of.
Right, because part of the milieu is like potential like group sessions and stuff like that, right?
Yeah. Mm-hmm.
Yeah. Okay, and then initiate safety measures according to unit policy. So this will probably look like suicide. I can't speak. This is why I shouldn't talk. Suicide risk. So initiate like removing things from rooms, rounding more frequently. Remove all cords, plastic bags, stuff like that. Even though she shouldn't have like a plan, but we don't want her to get any ideas, right?
Mm-hmm.
And then 4 is vital signs upon admission, and then daily. Obviously, we want to monitor her. She is what it said, like reduced appetite. So potentially, if she's not eating and drinking, like definitely vital signs are good to have. And then depending on how that thyroid is looking, maybe that'll be good too. But we want like a baseline and then see if anything changes.
It can be
Um,
it.
I feel like you're like our background entertainment, like just doing
I'm just getting
performance
that.
art.
I've looked at like 8 books right now.
Jeez. Okay, and then 5, regular diet, monitor intake. Obviously, she has had her appetite affected. We need to monitor nutrition, prevent any weight loss. And of course, like any timely interventions with that, everyone loves like a good boost, a little ensure moment. So stabilize her weight, maybe that'll help her with her energy, make her feel better. Any thoughts?
Yeah, I think that's good. Anything
Yeah.
that she, I guess, would take would be good.
Yeah, we definitely make sure she's getting food and just with her. And then we have some fun drugs. 6 sertraline, 50 milligrams PO per day. I looked it up in the Davis app I have. That's an SSRI, antidepressant. So it's gonna decrease the reuptake. So it's gonna make sure there's serotonin in that receptor to treat that depression. We're hoping that within a little while, Marilyn will be feeling better, more energy, less suicidal thoughts from that. And then we have trazodone, 50 milligrams PO, PRN for sleep. Repeat times 1. That is also an antidepressant, but off-label use is insomnia.
Mm-hmm.
I feel like I've seen it used for so many different things, but
It's probably sleep, yeah.
mm-hmm.
Wait, did they give us? They gave us these drugs, right?
Yeah, the left row, yeah.
Oh, that was already there. Okay.
Mm-hmm.
I'm wondering if like something got up with the thyroid labs, because you'd think there'd be a thyroid med if it's that.
right?
It's almost
If it's
looking like
pricey.
T3 and T4 are flipped in it. Because
Oh,
everything that I'm seeing is like T3 should go from 70 to 204, and T4 should go from 4 to 12.
Yeah, I'm thinking it's wrong.
Yeah, I'm thinking it's flipped. That's why I'm like freaking out over it because
mhm.
yeah. So I think it's just flipped.
Okay.
We'll just
Well, thank you for investigating in the back.
Yeah, I mean, okay. And then
Okay.
the TSH is at the highest level, which the TSH is what tells what the T3 and T4 needs to stay at or produce, I guess you could
Mhm.
say.
Right.
So,
You mean highest level of normal?
yeah. So it's within.
okay.
All right, we're recording again. We got cut off because of Zoom time and no one wants to pay for
That was honestly terrifying when it happened. Okay.
it. Okay, so where were we?
Okay, so we were almost at the end of our drugs. We were just talking about trazodone. It's probably for her sleep, and you figured out that her thyroid stuff was flip-flopped.
Yeah, and little of, I mean, within range. But yeah, I definitely
At
think
the
that
upper end. Okay, love it. Thank you for that.
until we get knocked down for it. What I could find. All right.
Appreciate it. We need all the points. Okay,
Maybe we'll
so
for points for figuring it out.
right, it was like a little nugget right there. And then we have what, lorazepam, everyone's favorite. Which one is but it decreases anxiety. It's a benzodiazepine, if I can say the words. Um, brand name, Ativan. Okay. For anxiety, agitation, and it's PRN. So whenever she's feeling anxious or agitated, Miss Marilyn can have some Ativan.
Sounds good.
Yeah. Any other thoughts before we go to the next section?
Uh, no, I think, yeah, I was gonna say because trazodone can be used for sleep. I didn't,
Mhm.
yeah, used for insomnia. Cool.
All right. So moving on to collaborative care nursing. What nursing priorities will guide your plan of care? So the nursing priority is ensuring the patient's safety by preventing suicide or self-harm. Is everyone okay with that one? Okay, so
Are you
I
gonna be able to remove access to the firearm? But
yeah, I don't know. But that would be like, I guess what I thought would be like the priority would be maintain safety and remove access to firearms or other lethal means. I don't know necessarily. I mean, everyone has their right, so it would
I mean,
be
I
a
think,
conversation, I guess. You
encourage removal, encourage giving it to a
yeah.
friend, giving it to somebody else.
I mean, we've removed access by like having her involuntary admit herself, right? So like that's
true.
the first step. I don't know.
So I wrote suicide prevention is the top priority when a patient expresses suicidal ideation and has access to lethal means. Removing or securing weapons and performing frequent safety checks are essential interventions to prevent self harm. And we hope that the patient remains safe and no self harm incidents occur. Number two would be establish therapeutic rapport and active listening. So, trust fosters openness and emotional processing, which is crucial for patients experiencing guilt, hopelessness, or isolation. And we would hope that the patient would verbalize their feelings and engage in their care plan. Three would be to monitor their mood, sleep, and appetite daily. This helps evaluate medication efficacy and symptom changes. And then our hope would be to that her mood would stabilize and imported self-care behaviors. Um, and then the last one would be encourage participation in group activity therapy to promote social interaction and adaptive coping skill development, hoping that she would increase her energy and social engagement. Anything else you guys want to add to that part?
No, I guess like for this point, like it'd really be like interacting with people like in the facility, right?
Mhm.
I don't know if they like, I mean, it's not rehab. They're not like, don't talk to people on the outside.
Right.
I'm
Like,
just curious if they facilitate any communication with that.
Does it?
I guess an important thing would maybe, I mean, I don't know exactly how it works, but like if she could get in touch with a social worker, that would help her connect to groups and stuff.
Yeah, I think it's kind of like discharging ideas, but
Yeah.
mhm.
Yeah, it's kind of hard in an emergency department exactly what you're gonna be able to do at that point and where it's going to go from there. Like if the provider feels like she needs to be admitted or anything like that, because then I think things change. But within an emergency department, it's kind of hard because you're not going to be able. How long is she going to be there? You know what I mean?
Right.
Mhm.
Because
More
that's
like,
truly how deep we're going to be able to get into like the interventions of it.
right. It's more just you have a conversation, I guess, and encourage it.
Yeah, for sure.
Really can't do anything more, I guess, maybe.
Yeah, you're like starting everything.
Yeah. Um, okay.
Okay,
Yeah.
what's our psychosocial priorities here?
Um, so caring, comfort, how can you engage and show that this patient matters to you? Physical comfort measures offer consistent presence and reassurance. So the rationale there would be providing consistent presence and emotional reassurance fosters trust, safety, and belonging, which are vital for recovery from depression. Demonstrating empathy helps reduce the patient's sense of isolation and validates her emotional experience. Hoping that the patient feels valued, supported, and begins to engage in therapeutic interactions. Emotional support, use therapeutic communication techniques like open ended questions and reflection. The rationale there would be therapeutic communication enables the patient to explore feelings of guilt and hopelessness safely, improving self awareness and emotional regulation. This also helps the nurse assess suicidal thoughts more effectively. And the hope would be that the patient would verbalize emotions openly, report that they report decreased distress, and show improved coping behaviors. Um, Spiritual care and support encourage exploration of spiritual or faith resources if they desire them. The rationale would be spiritual coping mechanisms are associated with enhanced hope, meaning, and psychological well being in patients with depression. Allowing space for spiritual expression respects the patient's personal values and promotes holistic healing. And the hope would be that the patient reports greater inner peace, strength, or spiritual connection that contributes to emotional stability. And then cultural care and support respect her identity as an African American veteran and her values. And the rationale would be acknowledging cultural background and military identity enhances therapeutic rapport and reduces mistrust or stigma. Cultural competence ensures care aligns with the patient's worldview and promotes inclusion. And the hope would be that the patient reports feeling respected, understood, and experiences culturally sensitive care that supports recovery.
I like it.
Yeah, I think
Anything?
there's a key point there when you're talking about the military stuff because, like, within the military, there's a lot of talk, like, even if you deployed, if you saw combat or anything like that. And then if you didn't, then you still feel like these depressive instincts and stuff like that. It just adds to it. Like, why do I have these and the other person doesn't? And so, like, what I've learned when it comes to like military personnel and stuff like that, like the stigma is a huge, like one of the biggest parts of taking that away and like letting them know, like you still deployed, you still went to a different country, you still went and did all these different things, and there was still the threat of something happening at any time. So like just because you didn't directly see combat, you're still in that area.
Right.
Yeah,
Oh,
it feels
this
like
is
secondhand smoke of trauma.
Yeah, one that's a great way to explain it.
Yeah.
it really goes back to like holistic care. Like as nurses, we keep looking at like labs and like physical
Yeah,
symptoms, but this is a good example of like a well-rounded. You have to look at them like as a whole.
yeah,
Because everything affects everything. So
100%.
Really.
okay. Are you guys okay moving on to the
Yeah.
next?
Yep.
Okay. So, what educational discharge priorities need to be addressed to promote health and wellness for this patient and for their family? I put number one, medication adherence and education. Marilyn should receive teaching on the importance of taking her medications daily as prescribed, even if she begins to feel better. She should be informed that antidepressant effects typically take 4 to 6 weeks to fully reach their efficacy. So, educating her about potential side effects such as nausea, fatigue, or sexual dysfunction, and advising her to not stop medication abruptly, which would help prevent withdrawal or relapse.
I think that's one of the most important reasons about having like either like admission during when they start SSRIs or like frequent check-ins is
Mm,
because it's going to take a while
yeah.
before they feel that effect.
And making
Mhm.
sure they're not stopping that when they start to feel better, because
Mm-hmm.
that'll catastrophically change the whole
Right.
situation.
Absolutely.
So,
Um, The second one would be suicide prevention and crisis resources. So, because Marilyn previously experienced suicidal ideation and has access to a firearm, discharge planning must include safety education, specifically removing or securing firearms and identifying emergency resources such as the 988 Suicide and Crisis Lifeline. The nurse should ensure the patient and family understand signs of worsening depression and when to seek help. The next would be follow up care and psychotherapy. So, encourage Marilyn to attend follow up appointments and participate in cognitive behavioral therapy or support groups, which improve mood regulation and reduce relapse rates. Consistent follow up enhances medication adherence, symptom monitoring, and coping strategies. And the next would be lifestyle modifications, promote balanced nutrition, adequate sleep, and regular exercise, all of which improve neurotransmitter balance and overall mental health. Moderate physical activity, such as walking 30 minutes most days, can significantly reduce depressive symptoms. Substance use education, discuss limiting alcohol consumption. We don't really know how much she's drinking, but that could be part of it, as alcohol can worsen depressive symptoms and interfere with antidepressant metabolism. Encourage healthy stress management strategies such as mindfulness, journaling, or relaxation exercise. And then also, if her family is around and are willing to support her, then we would educate her family members about the nature of depression as a biophysical illness, not a personal weakness. Involving family helps reduce stigma, increase emotional support, and ensure medication and safety compliance at home. And our expected outcomes would be that Marilyn and her family will verbalize understanding of medication instructions, safety precautions, and follow up care. The patient will identify coping strategies and crisis resources prior to discharge, and family members will demonstrate supportive behaviors that promote ongoing recovery and relapse prevention.
I feel like, yeah, like getting family involved, and like if we have friends or anyone like that participating, that really helps Marilyn in the long run.
Yeah, having people check in and be there.
yeah, I wish it would have stated more about her family
Yeah,
Mhm.
in it, because I mean, she moved back to her hometown, so we're assuming that
right.
she has family in the area. She talked about her grandmother, but it says, yeah. I went up and looked at the top again just to see like family wise, because it just didn't talk about it, but
Mhm.
assuming she has family in the area and friends from high school in the area still.
Yeah. But yeah, I like it. Any other thoughts, anyone? Um, yeah, I just wish we had more of a reference for like friends and family because I like the idea what you said, John, of being like, okay, like maybe we have someone take these guns for a little while.
Yeah.
But we need friends for that.
Right. Friends,
So we're
family.
kind of, yeah, so that would be a really important conversation to have with her, like throughout, like who's involved, and then maybe like the further she gets in treatment, the more she'd be like, there are people in my life, you know.
Right. Yeah.
Yeah, and I know most police departments have like a safe, like you can turn in firearms or anything like that. So if she doesn't have that family area and she's obviously we can't force her, she's okay with just getting rid of it in general. She could, I know that most police departments have situations like that.
Very cool.
Okay.
Yeah. Ooh. Any questions or anything like that? Obviously, we need to get our references in there, but
I think sounds great. I think substance abuse education is great, especially since we don't want her to get liver problems as well.
Yeah.
Yeah,
no. All good?
I think so.
Sounds
How's
good.
everyone feeling?
All right. I'm gonna stop the recording.